So inshallah today I will continue our interactive sessions, and I will continue thyroid guidelines, NICE British Thyroid Association guidelines and the European Thyroid Association guidelines published in the previous years. So this is part 2, and as I mentioned in every session, tools, files and videos are not for redistribution, and this is, I hope, to be interactive session. And actually we near the end of the thyroid gland disorders. Just we have some of specific topics, previous exam questions recall and solving questions from various banks, and also I prepare a specific session about practical aspect of the thyroid disorders, which will cover how to deal for every thyroid case in your clinical practice and in from diagnosis to the management. So this today's sessions I will cover these guidelines: Graves hyperthyroidism, European Thyroid Association guideline about management of Graves hyperthyroidism, and the updated or recent guideline about the management of pediatric Graves disease published this year. And also I will cover thyroid dysfunction following immune reconstitutional therapy and the Graves orbitopathy and iodine-based contrast media-induced thyroid dysfunction, and lastly the thyroid disorder prior to and during assisted reproduction. Wa alaikum assalam. So this is just a continue for the previous session, and I will cover the European Thyroid Association guidelines about thyroid association for the management of Graves hyperthyroidism. This is published since 4 years, and this is a very important practical guidelines. First of all, for diagnosis of, if you suspect any case of a Graves disease, the first one is to assess and diagnose a Graves hyperthyroidism biochemically. This is very important by doing TSH. TSH is the most specific and sensitive thyroid function test to assess primary thyroid disorder, primary hyper or primary hyper or hypothyroidism. If TSH is normal, this is the patient is euthyroidism and no need for assessment of or doing free thyroid hormone, free T4 or T3, either total or free T3, because normal TSH exclude the primary thyroid disorder. If TSH is low, in this situation, this is a case of hyperthyroidism or thyrotoxicosis. The next step is assessment of thyroid hormone, T4 and T3. If T4 and T3 is normal in this situation, this is a case of subclinical hyperthyroidism. If free T4 and T3 are elevated, this is overt hyperthyroidism. And this is very important. If T4 is normal and the T3 is elevated, this is a T3 toxicosis. And this is maybe an early stage of Graves disease. So don't do only free T4 in assessment of any case of thyrotoxicosis. We need to do T4 and T3, because in some cases T3 is elevated with normal T4, and this is a T3 toxicosis, which is early stage of a Graves disease. Another biochemical and serological test is TSH receptor antibody. A TSH receptor antibody, which is thyroid stimulating immunoglobulin, is very specific for Graves disease. If it is positive, so this is a Graves hyperthyroidism. If it is negative, we need to assess the other etiological cause of thyrotoxicosis. So hyperthyroidism in this situation with negative TSH receptor antibody, mostly due to toxic adenoma, toxic multinodular goiter, or subacute thyroiditis, painless thyroiditis. So this is very important. When we do thyroid imaging by thyroid sonography, which is not indicated in most cases of Graves' hyperthyroidism, except if we suspect thyroid nodule. In this situation, if a nodule is more than 2 centimeters, in this situation, it may indicate toxic adenoma. In this situation, the next step we should go to the isotope scan. If isotope scan presented by focal uptake, this is a toxic adenoma, not a Graves' disease, and the management of toxic adenoma usually radioactive iodine ablation or surgery. And we give antithyroid medication just a preoperative preparation. If a nodule is less than 2 centimeters, in this situation, isotope scan not indicated, because in this situation, this is mostly not toxic nodule. Because so we should know that a toxic nodule usually and in some references almost always more than 2, and in some references more than 3 centimeters to be toxic. So if you see a nodule 1 centimeter or even 1.5 centimeter, this is almost always not a toxic nodule and no need for isotope scan according to the guidelines and recommendation. But in the any question, if it TSH is low and the scenario presented by thyroid nodule, the next step is doing thyroid scan. But in a clinical practice, thyroid nodule to be toxic nodule must be more than 2 to 3 centimeter in dimension. And this table is very important because in every exam they will ask about a question about the mechanism of action of antithyroid drug, الكاربيمازول, ميسيمازول, بروبايل ثيوراسيل. The main mechanism of action usually is intrathyroidal inhibition of iodine oxidation or organification, inhibition of iodotyrosine coupling, inhibition of thyroglobulin biosynthesis, also will decrease follicular cell growth. They inhibit follicular cell growth. So, and this is usually why we use suppressive therapy in the management of differential thyroid carcinoma, because the antithyroid drug inhibit the follicular cell growth and usually decrease the incidence of recurrence of differential thyroid carcinoma. Another very unique and very important mechanism of action of propyl thyracil, this is a unique for propyl thyracil, inhibit extrathyroidal inhibition of conversion of T4 to T3 by inhibition of deiodinase type 1. And this is usually a question in the exam. This is also an important table to differentiate between mesimazole and the propyl thyracil, comparison between both drugs. Don't forget that the mesimazole, which is the active metabolite of carbimazole, the half-life is prolonged 6 to 8 hours, but the propyl thyracil is just 1.5 hour. And actually, the half-life of some of the drugs or some of hormones is a favorable question in the exam. For example, in the previous exam, they ask about the half-life of iodine 123, I think, or 131. And also in our previous exam, they ask about the half-life of growth hormone. So the half-life is very important, and anyone can collect this data to memorize before the exam. Also, duration of the action of mesimazole is prolonged, so can be given once daily, both mesimazole or carbimazole, but the propyl thyracil half-life is shorter than the mesimazole, 8 to 12 hours, so must be given in twice or 3 times per day to be effective and to cover 24 hours. Both drugs are cross the placenta, but the mesimazole cross more than the propyl thyracil, and both drugs are secreted in the milk, but can be given during lactation. Both drugs are excreted renally, and also don't forget that the mesimazole is more potent than the propyl thyracil. The mesimazole is more than 10-fold potent than the propyl thyracil. And also, of course, the normalization of thyroid hormone is is rapid with methimazole. It needs 6 weeks to normalization of thyroid hormone, but need a prolonged time with propyltyrosine. And also adverse events are more with propyltyrosine. So why we prefer methimazole or carbimazole than propyltyrosine? Because less side effects. Agranulocytosis, which means a neutrophil count less than 500 cell per 1 milliliter, more common in propyltyrosine. And the cross reaction of adverse events is common, and the compliance, of course, is more with methimazole or carbimazole. And this is very important algorithm for the management of patients with Graves' disease. Of course, if you see any case of untreated Graves' disease, usually we prefer methimazole or carbimazole. So any patient, any recent onset Graves' disease, either for adults or children, the best option is medical therapy. Especially if medical therapy induce a remission, high rate of remission. Methimazole or carbimazole is the only antithyroid medication approved in most of cases. The duration of carbimazole for adults is 18 months and for children 36 months. So this duration is very important. Yes, Dr. Mahawish, carbimazole and all criteria of methimazole the same for carbimazole. So carbimazole and the methimazole can be given once daily dosage, but the propyltyrosine must be divided. So this is a very important. Also, carbimazole half-life is 8 hours, like methimazole. Methimazole is converted. Carbimazole is converted in the liver to methimazole. So methimazole is the active metabolite of carbimazole. So the only criteria of methimazole the same for carbimazole. So this is very important. The duration of therapy of methimazole for Graves' disease is 1.5 years for adults and 3 years for children. If the patient cannot tolerate methimazole or non-compliance or personal decision, in this situation, we can start by radioactive iodine, especially if the small thyroid gland, also if there is inactive Graves' orbitopathy. Moderate to severe active Graves' orbitopathy, if we choose radioactive iodine, will exacerbate the Graves' orbitopathy. So in this situation, we prefer radioactive iodine if a Graves' orbitopathy is inactive. And of course, surgery is the best option if there is a nodule in the thyroid in a patient with Graves' disease, especially if there is a suspicion of malignancy. Also, if the goiter is more than 50 milli, this is a huge goiter causing compression. In this situation, surgery is the best option. Also, if there is active Graves' orbitopathy and medical therapy is not tolerated, in this situation, surgery is the best option. Actually, a relapse is very common in a case of a Graves' disease after treatment of medical therapy by this duration. So a relapse is in most cases about 50 to 60%. So if the patient after this duration at 1.5 years or 3 years in children and hyperthyroidism is still persistent, in this situation, before stopping anti-thyroid medication, we should assess TSH receptor antibody. If a TSH receptor antibody is still positive after 1.5 years for adults and after 3 years for children, in this situation, we should continue methimazole for another 1 year. Or another option to go to the definitive treatment by radioactive iodine ablation or surgery. Then after another 1 year of treatment with methimazole, if TSH receptor antibody is negative, in this situation we can stop methimazole. If it's still positive, in this situation we should go to radioactive iodine ablation or surgery. What relapse? Relapse is very common with methimazole, as I mentioned, or with anti-thyroid medication. After stopping anti-thyroid medication, we should reassess the patient by TSH and thyroid hormone. If the patient is relapsed after treatment for this specific duration, we have two options. The first one is to go to the definitive treatment by radioactive iodine or surgery, because if we give another course of carbimazole, usually remission will not occur. Another very important option is by using long-term low-dose methimazole. This is a very important arm in the management of relapse after medical therapy, long-term low-dose methimazole. And this is usually very important, especially in the elderly people who refuse radioactive iodine and also not candidate for the surgery. So long-term low-dose methimazole is very important modality for treatment for Graves' disease after a relapse. So I will focus on some of the recommendation, and before starting of this recommendation, what about the adverse events of the antithyroid drug? And this is a favorable question in the exam, in the SCE or European board exam. There are very common side effects like skin rash, and this is a mild and moderate side effects like skin rash, urticaria, and this is can be treated by antihistaminic drug. Just antihistaminic drug can improve skin rash and urticaria. And in minor cases, we need to stop the medication. But in this situation, if the patient on carbimazole and complaining from severe urticaria or skin rash, we can give a propylthiouracil. Another common side effect, which is arthritis, fever, and the transient mild leukopenia, decrease leukocytic count, mild decrease of the leukocytic count. Another very important and fatal side effects and very rare side effects is a granulocytosis, which means the granulocyte or neutrophil is less than 500 cell per cubic milli. And another rare side effects, which is gastrointestinal and abnormality of the taste and the smell. Don't forget that once a granulocytosis occurs and you diagnose or suspect a granulocytosis, in this situation we should stop antithyroid medication and assess CBC. If a granulocyte is less than 500, in this situation, this is a case of a granulocytosis, we should treat it by stopping the carbimazole and giving antibiotic and go to another modality for treatment. If the patient presented by granulocytosis on carbimazole, in this situation, propylthiouracil is contraindicated because there is a cross reactivity between propylthiouracil and carbimazole. And actually, granulocytosis is fatal in most of cases. So once you suspect a granulocytosis, you need to stop antithyroid medication immediately, and this should be a written information, and you should reassess this in every patient. And a granulocytosis usually occurs abruptly, so a follow-up by doing CBC in a patient receiving carbimazole is not recommended because a granulocytosis occurs abruptly. And another very rare side effects of antithyroid medication, which is aplastic anemia or thrombocytopenia and vasculitis. Don't forget, this is ANCA positive vasculitis, and this occurs with propylthiouracil, and also hepatitis and hypoglycemia and cholestatic jaundice with carbimazole or methimazole. Yes, routine CBC testing is not recommended by the guidelines, and I will put this recommendation later on. But doing CBC and liver function test is recommended before starting antithyroid medication. But routine doing CBC or liver function test, no recommendation about this in the guideline. Dr. Khalid. So I will start by some of important recommendations from these guidelines. What about the radioactive iodine treatment if indicated? If antithyroid drugs are used before radioactive iodine therapy, we should stop in antithyroid medication 1 week before starting radioactive iodine. And this is very important. The dose of radioactive iodine treatment is not dose, and usually in most of cases we not use a dose calculation, we just use a fixed dose for radioactive iodine. And also pregnancy and breastfeeding are absolute contraindication for radioactive iodine therapy. Pregnancy, we should doing a pregnancy test even if the female is not pregnant, to be sure it is not pregnant, to do radioactive iodine ablation. And for breastfeeding, it is if we decide to give radioactive iodine ablation, so we should stop breastfeeding. And also, conception should be postponed until at least 6 months after radioactive iodine in both male and female. And this actually is very important, because in Oxford Handbook you will find that we should postpone pregnancy for males by 4 months. And also in the last guidelines published by European Thyroid Association, they recommend actually for males, and I will cover it in the assisted reproductive technology and thyroid dysfunction, the latest guidelines today, inshallah. They prefer to postpone for male 4 months. Clinically is very difficult. Dr. Shavan asked about how do we differentiate between sore throat related to carbimazole and bacterial viral sore throat. This actually is clinically is not accurate. So once you suspect a granulocytosis, we need to stop antithyroid drug and doing CBC. If his leukocytic count is less, granulocyte or neutrophil is less than 500, this is a granulocytosis. If a granulocyte is more than say 500, this is a case of neutropenia and can occur with a granulocyte with antithyroid drug, and we can continue carbimazole without any fatal abuse. Dr. Asma asked about an exam we choose 4 or 6 months for male. Actually, I will recommend if SCE, I will choose for male 4 months, and for European board, I will choose 6 months. And actually, in the exam, this is usually a question in the exam for male and female, actually. And this is very important. For European board, I will choose 6 months, and for SC exam, I will choose 4 months for male. But for females in both exams, I will choose 6 months. Okay. Surgery is another very important modality for treatment of Graves' disease. If surgery is selected, total thyroidectomy is the procedure of choice. Subtotal thyroidectomy is obsolete nowadays, so total thyroidectomy is the preferred, is the procedure of choice for management of Graves' disease. And euthyroidism should be restored by antithyroid drug prior to surgery to avoid the peri or post-operative exacerbation. And also don't forget that vitamin D deficiency should be corrected before surgery to avoid a risk of hypocalcemia. Also, a solution containing potassium iodide can be given for 10 days prior to the surgery to decrease thyroid vascularity and decrease thyroid gland thyroid hormone. And this is how to treat Graves' disease in the presence of Graves' orbitopathy. Actually, this is a very important. Radioactive iodine is only not indicated in a case of moderate to severe and active Graves' orbitopathy. In this situation, radioactive iodine is not cannot be used. And also, of course, in situs-threatening Graves' orbitopathy, radioactive iodine will exacerbate the Graves' orbitopathy. But in another situation like mild and inactive or mild and active Graves' orbitopathy, in this situation, Graves' radioactive iodine can be used. But in this situation, we should give steroid prophylaxis in selected cases. Even in a case of moderate to severe and inactive Graves' orbitopathy, we can use radioactive iodine with steroid prophylaxis. And don't forget that in mild case of Graves' orbitopathy, mild or moderate to severe Graves' orbitopathy and inactive, so inactive Graves' orbitopathy, selenium supplementation for 6 months can be used. So medical therapy is the best option in Graves orbitopathy for management of Graves disease in the presence of Graves orbitopathy. Also, a surgery can be used in mild and moderate inactive cases. What about pregnancy and postpartum? This is a very important. Women with Graves disease of reproductive age should be offered preconception counseling and be rendered EU thyroid before attempting to be pregnant. Also, it is recommended to switch from carbimazole or mesimazole to propylthiouracil when planning pregnancy and or during the first trimester of pregnancy. Once the female gets pregnant, we should transfer from mesimazole to propylthiouracil. So, if the female is preparing to be pregnant, it is recommended to switch to propylthiouracil. Usually 3 months or from 3 to 6 months before getting pregnancy. And also a TSH receptor antibody is very important marker during the pregnancy. So in any female presented by a previous history of Graves disease and get pregnant, even if she treated by a previous antithyroid drug or radioactive iodine ablation, in this situation we should assess TSH receptor antibody because it needs a very long duration to be weaned from the blood. If a TSH receptor antibody is elevated, we need to repeat it at 18 to 22 weeks to assess neonatal hyperthyroidism. If a TSH receptor antibody is more than 3 times the cutoff value, in this situation we should monitor the fetus for thyroid dysfunction through the pregnancy, and we can diagnose fetal thyrotoxicose by heart rate more than 160 and also presence of goiter, fetal goiter with for the sonography. And also during the pregnancy, we should, if the female on antithyroid drug, we need to the lowest possible dose of antithyroid drug should be given, and block and replacement therapy is not recommended. How to follow up? Usually we follow up pregnant female with Graves disease by free thyroid hormone or total thyroid hormone, but in this situation we should adjust a total thyroid hormone according to the gestational age because increased TPG will increase total thyroid hormone reference range. So we should adjust total thyroid T4 regarding gestational age. So we should measure the free T4 and the TSH every 2 weeks after the initiation of the therapy during the pregnancy and every 1 month after achieving the target value. So a change from propylthiouracil to mesimazole should be considered if antithyroid drugs are required after 16 weeks of gestation. Also, in every woman with low dose of mesimazole, less than 5 to 10 milligram of mesimazole, or propylthiouracil is less than 50 to 100 milligram per day. In this situation, we can try to stop this antithyroid medication prior to gestational age of 6 to 10 weeks. And actually immune reconstitutional therapy, we will cover this guideline. So management of Graves in elderly and children and adolescent, the guidelines recommend a long-term mesimazole or carbimazole should be considered as a satisfactory treatment for older individuals with mild Graves disease. And also propylthiouracil should be avoided in children and adolescents because previously propylthiouracil is recommended as a first choice in a pediatric Graves disease, but nowadays propylthiouracil should be avoided in children and adolescents because a risk of liver cell failure. Long-term methimazole or carbimazole should be the mainstay treatment in children with Graves' disease. So the least period for giving methimazole is 3 years in children. Thyroidectomy is the primary definitive therapy in children, but in post-pubertal children, radioactive iodine can be considered. So radioactive iodine is contraindicated before the age of 5, and I will cover this. And after puberty can be used. Between 5 to 10 years of age may be indicated in some situations. So thyroidectomy is the best option in for management of definitive treatment for Graves' disease in children. Actually, immune reconstitutional drug alniutuzumab is a very important drug used for the management of multiple sclerosis, and this is actually a recent topic. So in the exams they will ask a question about this drug and also for check immune checkpoint inhibitor. Actually, about 20 to 30% of the patient receiving this drug will develop the TSH receptor antibody positive Graves' disease. So this drug is very important because side effects or thyroid dysfunction is very common, and I will cover it in a specific guidelines published by ETA. So Graves' hyperthyroidism precipitated by immunomodulatory therapy is not a mandatory indication to stop this drug, nor it is a mandatory indication for definitive therapy of hyperthyroidism. So most cases require just treatment by antithyroid drug for just 1 year, and after that most of patients were remit. And also sequential monitoring of serum TSH receptor antibody level can be used to guide the duration of therapy in these situations. And actually this is the last slide in the Graves' disease, and also I will cover this is the recent guidelines published since a few months about European Thyroid Association guidelines for the management of pediatric Graves' disease. And this is important. I just put it after previous guidelines adults Graves' disease because both topics are to compare both approach for management of Graves' disease in adults versus pediatric age group. TSH receptor antibody usually presented for about 1 year or more after radioactive iodine ablation or after even after starting of antithyroid drug. But after surgery, TSH receptor antibody, most of them are weaned rapidly. So I will cover management of pediatric Graves' disease guidelines published by the European Thyroid Association in 2022. And what is the difference between management of Graves in adults versus pediatric? First of all, as I mentioned previously, carbimazole or its active metabolite methimazole should be used in young people with Graves' disease. Propylthyracil should not be used. Initial antithyroid drug, initial dosage of antithyroid drug for methimazole is 0.15 to 0.5 milligram per kilogram of methimazole. But I will focus on carbimazole because it is available in most of our countries. The dosage of carbimazole for pediatrics is 0.25 to 0.75 milligram per kilogram of carbimazole daily dose. And of course, as I mentioned, methimazole and carbimazole have a prolonged half-life, so both drugs are given once daily. We have two regimens or two approaches for management of Graves' disease in adults and pediatrics. The first one is dose titration approach, and another one is a block and replace approach. What about the dose titration approach? In this situation, I will start by carbimazole 0.25 to 0.5 milligram per kilogram carbimazole, which will normalize the thyroid hormone in pediatrics in most patients within 4 to 6 weeks. And after that, we will reduce the dosage of carbimazole by 25 to 50% according to the thyroid function test. In a very rare situation, we need a larger dose of antithyroid drug, more than 0.5 or 0.75 for carbimazole, which can be administered in more severe symptomatic cases. In some rare situation, the treatment regimen may not require adjustment if FRT4 and FRT3 is elevated, but TSH is normal. In this situation, I will not reduce the dosage of carbimazole. A block replace approach is not recommended because more side effects, and in this situation, we start by a larger dose of carbimazole, 0.5 to 0.75 milligram per kilogram carbimazole for about 1 month, and then we will introduce levothyroxine, which can be introduced in an age and weight appropriate replacement dose as the FRT3 fall into the reference range. In this situation, we will start, for example, if by carbimazole 0.3 milligram per kilogram carbimazole. This is a large dose of carbimazole. If thyroid hormone concentration, especially FRT3, don't fall as expected. Of course, a dose titration approach is preferred in children. For both approaches, we need to reassess the case, the child, every 4 weeks for the first 3 months, and then reassess every 2 months, 2 to 3 months later on. And of course, the white cell count, including neutrophil and liver function tests, as in adults, should be checked at the baseline. And of course, thyroid hormone concentration, free thyroid hormone, should be normalized in most patients in first 6 weeks. And don't forget that TSH can remain suppressed for several months as in adults. So don't follow your patient by TSH alone. We should do FRT4 and FRT3 with TSH. But decreasing in dose usually by free thyroid hormone. Patient and families should be counseled about the antithyroid drug side effects, and this is very important. And also, don't forget that alternative treatment, surgery or radioactive iodine, should be discussed for every patient who are thyrotoxic despite larger dose of carbimazole, which means the carbimazole dosage is more than 1.3 milligram per kilogram per day. This is a large dose of carbimazole. In this situation, remission is very, very, very rare. In this situation, we should discuss definitive treatment by total thyroidectomy or radioactive iodine ablation. As in adults, the TSH receptor antibody can be used to predict the likelihood of remission. The antithyroid drug is normally administered for at least 3 years for children, and only stopped if the TSH receptor antibody level been low for several months. And longer courses of antithyroid drug, more than 5 years, should be considered if the likelihood of remission is low on the basis of the disease characteristics at the presentation and a positive TSH receptor antibody. A remission rate after the antithyroid drug for pediatrics after treatment for 3 years is between 20 to 30% after a year of antithyroid drug. Patients who relapse following the course of antithyroid drug have an option of returning to antithyroid drug for a longer duration, and in most cases, a remission will not occur, or choosing a definitive treatment. And this choosing the factors that influence some of this regimen, the age and the stage of the education. There is no established rule for immune modulation drug for the management of Graves' disease in pediatric age group. If we choose radioiodine ablation for the definitive management of pediatric Graves' disease, in this situation, we should avoid radioactive iodine before the age of 5. From age of 5 to 10 years, we can use it when surgery is not realistic option and there is no contraindication to radioactive iodine use in patient. So in age group 5 to 10 years, in this situation we can use radioactive iodine ablation only if the surgery is not candidate. After 10 years of age, we can use radioactive iodine ablation without a contraindication. And as in adults, anti-thyroid drug should be stopped before radioactive iodine by at least 3 to 7 days. In adults, they mention 1 week, but here 3 to 7 days, and this is the ideal one. Radioactive iodine ablation should be avoided in the presence of active Graves' orbitopathy. What about thyroidectomy? Thyroidectomy is a very important option in the management of pediatric Graves' disease, and a surgeon must be high volume thyroid surgeon. A total thyroidectomy is the best operation of choice, and of course, euthyroidism should be obtained biochemically before surgery. A preoperative treatment like adults by iodine, beta blocker, and glucocorticoid may be needed. And also, as in adults, vitamin D deficiency must be corrected before the surgery. And also, as in adults, levothyroxine treatment should be started soon after the thyroidectomy, in the next day after the surgery. And this is a very important clinically, because we see a lot of cases after total thyroidectomy, the patient presented after a few months without a replacement therapy and presented by typical phase of hypothyroidism. What about the management of pediatric Graves' orbitopathy? Actually, this is similar as adults Graves' orbitopathy. Mild Graves' orbitopathy symptoms without inflammation should be received selenium supplementation. Rare cases of moderate to severe active Graves' orbitopathy should receive intravenous glucocorticoid, intravenous, not oral. Intravenous glucocorticoid is the first option for management of moderate to severe active Graves' orbitopathy in adults and children. A chronic inactive stable Graves' orbitopathy may reduce the quality of life. It can be treated surgically as in adults, but decompression surgery should be postponed until the facial skull has fully grown, and this is important. The risk of thyroid cancer actually is decreased, but children and adolescents with Graves' disease should have who have a palpable thyroid nodule should assessed the same as in adults, but don't forget that the risk of malignancy in this situation is more than in adults. So in this situation, we should evaluate the thyroid nodule by thyroid sonography and proceed to final aspiration cytology, and if needed, undergo total thyroidectomy if suspicious of malignancy. And this table clinically is very important because this is a factor associated with improved likelihood of remission following the antithyroid drug. Who will remit more than others? If older age is remit more than others, female sex, some of ethnicity like Caucasian, if the goiter is small in size, if mild biochemical initially, if lower TSH receptor antibody, if there is a history of other autoimmune thyroid disease, also with long duration of antithyroid drug, the patient will remit more and more. And actually, most of these factors depends upon adult studies. And this is the last slide in this guidelines, a comparison between radioactive iodine ablation and the total thyroidectomy for children. So don't forget that radioactive iodine ablation is absolute contraindicated in pregnancy and in breastfeeding, and also in patients under 5 years of age. Also is not contraindicated in active orbitopathy. And another relative contraindication if the patient between 5 to 10 years of age in active Graves' orbitopathy in larger goiter, because in this situation we usually need second dose of radioactive iodine. what is radioactive iodine ablation is prescribed as orally solution or capsule, and usually hypothyroidism occurs after weeks or months, and there is a long-term sum of risk. Theoretically, neoplasia risk may be increased, especially in a younger patient. And in this situation, mandatory advice not to become pregnant within 6 months after radioactive iodine for male and female. And also a smaller chance of disappearance of TSH receptor antibody compared to total thyroidectomy. And so increase the risk of fetal or neonatal hyperthyroidism because the TSH receptor antibody pass the placenta to the fetus. What about the total thyroidectomy? The main indication if there is a obstructive manifestation, and also euthyroidism state occurs immediately after total thyroidectomy. So in any case, if we require euthyroidism rapidly, in this situation, total thyroidectomy is the preferred option. Also, in a patient less than 5 years, total thyroidectomy is the best option. Actual contraindication to total thyroidectomy is none, except if the surgeon is not well qualified. And of course, 100% after total thyroidectomy, the patient will be hypothyroid, so replacement therapy should be immediately the next day after the surgery. Hypothyroidism is achieved rapidly, and of course, a risk of the surgery usually transient, but in some situations, permanent hypoparathyroidism occurs. Hypoparathyroidism, recurrent laryngeal nerve injury or palsy, and this is the last slide in this guidelines. If anyone want any question about the Graves guideline, it is welcome.
Dr. Khaled?
Dr. Khaled?
Yes.
Dr. Khaled, I ask about thyroid cells with the pregnancy. Now, if the patient on carbimazole, the maximum dose, okay, how to the shift the proper seed according to the dose? Because no clear guideline, the initial dose and the maximum dose.
Actually, 10 milligram of carbimazole is equivalent to 6 milligram of mesimazole, equivalent to 50 milligram of propyl thyracid.
Okay, Dr. Khaled, now I have patient, okay, and carbimazole, the maximum dose, 60, okay? Now the patient newly discovered pregnant. So when I shift, calculate 600 propyl or just small dose then upgraded?
لا, start by the large dose as the patient is thyrotoxic. So dose titration will start usually by the large dose. One tablet of carbimazole is equivalent to 1 tablet of propyl thyracid. So 5 milligram of carbimazole is equivalent to 50 milligram of propyl thyracid. Not 10 milligram carbimazole is equivalent to 50 milligram. So 5 milligram of carbimazole is equivalent to 50 milligram of propyl thyracid. So we change 1 tablet to 1 tablet of propyl thyracid.
Okay, another question. If the ultrasound feature toxic multinodular goiter, need to assist trap during pregnancy or not?
Actually, if toxic multinodular goiter usually treated radioactive iodine or surgery, but in this situation we should render the patient euthyroid by antithyroid drug. If we sure it is a toxic, so no need to TSH receptor antibody, but we cannot be sure 100% it is a toxic adenoma, except if you do thyroid scan or TSH receptor antibody. So we cannot be sure it is a toxic adenoma except by thyroid scan, which is a contraindicated during the pregnancy and lactation, or TSH receptor antibody. So in this situation, I will prefer to doing TSH receptor antibody, because if a TSH receptor antibody is positive in this situation, we should reassess nodules by doing fine needle aspiration cytology according to the risk pattern of this nodules. If TSH receptor antibody is negative, in this situation it is mostly toxic nodule, and in this situation a fine needle is not indicated.
Okay, Dr. Khalid, the last question. If the patient now the maximum dose of anti-thyroid medication during the pregnancy, any guideline approved use prednisolone during the pregnancy or not approved during the pregnancy? If the patient
Actually, we
resistant.
use corticosteroid in the situation in which a reduction of thyroid hormone is not obtained after using of antithyroid drug. So in any case of a grave disease, if we give a high dose of carbimazole and after 1 month a reduction of thyroid hormone is not as expected, in this situation we can use just a trial of corticosteroid for a short duration. In this refractory cases only, but not in all cases.
Okay, Dr. Khalid, thank you.
Another question from Dr. Mawish: cytotoxic because of any cause. If follow up, which indicate should use free T3 or T4 or TSH? Actually, and I mentioned this in. And I will focus about this in the practical thyroid session, inshallah, later on. But usually, TSH will be suppressed for a long duration. So, the follow-up of a patient with a grave disease don't depend upon TSH alone. In this situation, we should depend upon T4 and T3 because T4 will normalize it rapidly, T3 will normalize it later on, and we will decrease the dose of antithyroid drug after normalization of both T3 and T4. And this is a very important actually in clinical practice. So, the follow-up of patient with grave disease should be TSH, free T4, and free or total T3. What is the maximum dose of carbimazole? Actually, about 40 milligram. Most of patients not require more than 40 milligram. But in a very, very rare situation, we may need 60 milligram. But most of cases, 40 milligram is sufficient enough. Follow-up of the relapse after stopping carbimazole every month or not, according to your case. If the patient is symptomatic in this situation, we should reassess Dr. Khalid thyroid function test. But if the patient is not symptomatic, we can do thyroid function test after 2 months for 6 months, and then after 3 months, and then once yearly. And actually, after 1 or 2 years after stopping of antithyroid drug, the risk of relapse is very, very rare, not common. But actually, if the patient is symptomatic at any time, we should do a thyroid function test and reassess thyroid function test. So I will move to this European Thyroid Association guidelines on the management of thyroid dysfunction following immune reconstitutional therapy. And actually, this drug is nowadays usually in the exam they will give a question about this drug. And actually, this drug, which is for example, almutuzumab, which is used for multiple sclerosis nowadays. Thyroid dysfunction usually occur as a complication of immune reconstitutional therapy. Almutuzumab, which is a pan-lymphocyte depleting drug. Also, another situation in which thyroid dysfunction will occur in a patient received antiretroviral therapy. Highly active antiretroviral therapy will presented by thyroid dysfunction. Also, thyroid dysfunction occur the same path of mechanism in a patient undergoing bone marrow or hematopoietic stem cell transplantation will be presented by thyroid dysfunction. So this guidelines is recommended and actually it is very important. Before starting of immune reconstitutional therapy, in this situation, we should assess thyroid status by doing TSH measurement in all patients before IRT. The free T4 and the free T3 is indicated only if the TSH is low, like in any case of thyrotoxicosis. So TSH is mandatory. If TSH is low, in this situation, we should assess the free T4 and the free T3. A baseline or a previous thyroid disease is not a contraindication for treatment by IRT. Also, active thyroid eye disease and the cardiac disease patient should be not received IRT because there is a significant risk for thyroid dysfunction. So, active thyroid eye disease and cardiac disease where thyrotoxicosis should be significant risk or contraindication to immunoconstitutional therapy. TPO and the TSH receptor antibody is not indicated before doing IRT. Also, thyroid sonography and scintigraphy is not recommended before starting IRT. Monitoring of the patient receiving IRT, this is a very important. Initially, we should doing TSH testing to assess for both IRT thyroid dysfunction, depending on the local resources, and the FAQ may be also routinely measured. We should repeat TSH within 1 month if the TSH is low, between 0.1 to 0.39. So, if grade 1 subclinical hyperthyroidism, in this situation, we should repeat TSH within 1 month. But if TSH is less than 0.1, in this situation, we should repeat TSH within 2 weeks. With 3 to 4, if TSH repeat TSH testing within 2 weeks together with 3 to 4 if TSH is elevated, if the patient is hypothyroidism, or if TSH is suppressed less than 0.1. So in a case of a grade 2 subclinical hyperthyroidism, we should repeat TSH after 2 weeks with 3 to 4. And if TSH is elevated, the patient is hypothyroidism. In this situation, I will repeat TSH after 2 weeks. How frequently should the thyroid function be tested after IRT? Actually, you should doing TSH every 3 months. And also, it is not recommended routinely for doing TSH monitoring following a heart in HIV patient. So, in the patient receiving almutizumab, in this situation, we should follow by TSH every 3 months during treatment. But with the heart treatment, no requirement for routine TSH monitoring during the therapy. How long post-IRT routine thyroid function test should be performed? Actually, we routinely do a TSH every 3 months for 4 years from the last almutizumab treatment, and I will cover this in the next figure. And thyroid autoantibody is not recommended routinely. So usually during a treatment, we should do TSH as a baseline. And after treatment, we should do TSH every 3 months for a duration 4 years following the last cycle of almutizumab. After 5 years, no need for assessment of TSH, except if the patient is symptomatized. So, the follow-up is recommended 4 years following the last cycle, TSH every 3 months. This is for almutizumab. Managing and referring patients who develop post-IRT thyroid dysfunction, we don't recommend routine thyroid sonography and scintigraphy as I mentioned. What are the recommendations for a pregnant patient or patient pregnant? Also, we suggest that thyroid function of the woman pregnant or seeking pregnancy within 4 months of the last IRT should be monitored more frequently, for example, monthly by doing TSH. If biochemical is consistent with thyrotoxicosis, we recommend TSH receptor antibody and or thyroid scan. And also we can assess thyroid status vascularity by ultrasonography color flow Doppler. So if the patient is thyrotoxic post-IRT, in this situation, the same as thyrotoxicosis, we should assess TSH receptor antibody, thyroid scan, and color flow Doppler. We recommend to promptly initiate treatment if the patient is symptomatic. This is when to treat by carbimazole, cytotoxicose after IRT, if the patient is symptomatic or if the patient at high risk, for example, a pregnant or cardiovascular disease or thyroid dysfunction persists more than 3 months. Yes, most of this is for altuzumab only, Dr. Mahawish. So when to treat thyroid dysfunction, if the patient is symptomatic, if the patient at high risk like pregnant female or cardiovascular disease, or if the patient thyroid dysfunction persists more than 3 months. In this situation, we recommend treatment. What is the management of post IRT Graves' disease? In this situation, if the patient persistent hyperthyroidism or the patient is symptomatic within 12 to 18 consecutive months, we should recommend a treatment by carbimazole. A block and replace regimen by high dose of carbimazole with levothyroxine is recommended only in situations if there is a fluctuation in the thyroid status, if there is variability in the thyroid status unexplained by change in antithyroid drug. In this situation, a block and replace regimen is the preferred regimen if there is a fluctuation from hyper to hypo by using antithyroid drug alone. In this situation, it is a block and replacement regimen is preferred. A radioactive iodine ablation and surgery is considered for hyperthyroid Graves' disease in a case of relapsing disease, or the patient cannot tolerate drug, or the patient preference or uncontrolled fluctuation course like variability in the thyroid status unexplained by change in the antithyroid drug. And this algorithm demonstrates how to manage cytotoxicosis presented in a patient receiving almutuzumab. If we see TSH, abnormal TSH, we should repeat testing. If TSH is low, in this situation, I will order FRET4 and FRET3 and TSH receptor antibody. If TSH receptor antibody is negative in this situation, I should go to the thyroid scintigraphy. If TSH receptor is positive in this situation, this is a case of a Graves' disease. So, if the TSH receptor antibody is negative, I will go to the thyroid scintigraphy. If there is a patchy increased uptake, this is a toxic adenoma. In this situation, I will go to the treatment as a local guidelines for by radioactive iodine ablation or the surgery in this situation. If the thyroid scan is reduced uptake, in this situation, this is a case of thyroiditis, we should go to just a conservative treatment, supportive treatment by beta blocker if indicated. If the uptake is elevated, this is a case of a Graves' disease, and I will go as a positive TSH receptor antibody algorithm. If a TSH receptor antibody is positive from the start, this is a case of a Graves' disease. In this situation, I give a trial of antithyroid drug after 3 months of low TSH. So the treatment should be started after persistent hyperthyroidism by 3 months, except if the patient is symptomatic or the patient high risk of side effects or cardiovascular disease, like a patient with cardiovascular disease or pregnant female. If we start antithyroid drug, we will start a trial of carbimazole for 1 to 1.5 years, and after that a trial of antithyroid drug. If and monitor for relapse. If the patient remains euthyroid, this is a remission. If abnormal thyroid function test, in this situation, I will go to radioactive iodine ablation or surgery. If the patient also cannot tolerate an antithyroid drug or the patient preference or uncontrolled fluctuation, in this situation, I will go to the radioactive iodine ablation or total thyroidectomy. So this is a very important advice for the management of thyrotoxicose in a case of almutuzumab treatment. The first step is assessment of a free thyroid hormone with TSH receptor antibody. If the TSH receptor antibody is negative, the next step is thyroid scan. If the patient is toxic multinodular goiter, this is treated by local guidelines. If reduced uptake thyroid scan, this is a thyroiditis, just a beta blocker and supportive treatment. If increased uptake, this is a case of Graves' disease. If the TSH receptor antibody is positive, I will start antithyroid drug after 3 months of persistent low TSH, and I will give antithyroid drug for 1.5 years and a trial to stop antithyroid drug. If the patient remit, this is okay. If not, if relapsed in this situation, I will go to radioactive iodine ablation or thyroidectomy, or start by radioactive iodine or thyroidectomy if the patient cannot tolerate the medication, or patient preference, or uncontrolled fluctuation course. So this is a case of thyroid dysfunction in a form of thyrotoxicosis. What about the post-IRT hypothyroidism? We recommend in any patient TSH is elevated, we should go to measure TSH receptor antibody with TPO antibody. Because the TSH receptor antibody, there is a stimulating antibody which causes Graves' disease and inhibiting antibody which causes hypothyroidism. But if TSH receptor antibody is positive with hypothyroidism, relapse from hypothyroidism to thyrotoxicosis is common. How to treat and who to treat? They recommend commencing levothyroxine in patient with overt hypothyroidism. But don't forget that they recommend treatment by levothyroxine in a mild case of subclinical hyperthyroidism and persistent more than 3 months with symptoms. So a subclinical hypothyroidism should be treated if the patient is symptomatic and persistent more than 3 months. And of course, how to monitor? By monitoring TSH and free T4 every 3 months for the first year after thyroxine initiation. We suggest monitoring TSH free T4 every month during 6 months after levothyroxine initiation in the case of the TSH receptor antibody is positive. Then every 3 months, so we recommend follow-up monitoring TSH free T4 every month for 6 months if the TSH receptor antibody is positive, and then every 3 months if stable, and then every year. And actually we should a trial of stopping levothyroxine after 12 months to determine if hypothyroidism has resolved or not. Dr. Mawish asks, can directly go to the radioiodine rather than giving a trial of antithyroid drug if no contraindication? Actually, yes, but there are 2 options: giving antithyroid drug for 1 year, or giving radioactive iodine and the patient should be put in the replacement therapy for life. If anyone want to choose, they will choose antithyroid drug because the remission after antithyroid drug in this situation is good. So we usually choose a radioactive iodine or surgery only in the situation in which the antithyroid drug is not candidate or the patient preference. How should post-IRT thyroiditis be managed? Actually, thyroiditis should be managed only symptomatic support, just a beta blocker. What about Graves' orbitopathy? Is the same as Graves' orbitopathy, the same way as a spontaneous disease of a Graves' orbitopathy. And this is the last slide from these guidelines, how to manage hypothyroidism. Of course, if there is abnormal TSH in this patient, TSH elevated in this situation, we should measure free thyroid hormone, free T4, TPO antibody, and TSH receptor antibody. If TSH receptor antibody is positive, this is have a higher risk of later thyrotoxicosis. So you need a follow-up every month for 6 months. But if it TSH receptor antibody is negative, this is usually a case of mostly Hashimoto's thyroiditis or autoimmune thyroiditis. And in this situation, I will start by levothyroxine in a case of overt hypothyroidism, low free T4 with elevated TSH, or in a case of symptomatic subclinical persistent hypothyroidism more than 3 months. And in this situation, I will check TSH and free T4 every 3 months for the first year, then as per protocol of hypothyroidism. But if a TSH receptor antibody is positive, I will check TSH and free T4 every month for the first 6 months, and then every 3 years for 1 year. And I will try to stop thyroxine after 1 year. But don't forget, before stopping levothyroxine, we should exclude the pregnancy or female seeking pregnancy, because the target of the TSH in this situation is less than 2.5. And of course, we should consider definitive treatment by radioactive iodine or thyroidectomy if frequent fluctuation in the thyroid status. So this is when we consider a treatment by radioactive iodine ablation or total thyroidectomy in a case of hypothyroidism, if there is a fluctuation in thyroid status between hypo and hyperthyroidism. So I will start by this very important guidelines, 2021 European Group on Graves Orbitopathy Clinical Practice Guidelines for the Medical Management of Graves Orbitopathy. And actually in the final exam there are 2 questions about Graves Orbitopathy. So this is a very important. In every case of Graves Orbitopathy, treatment decisions are based on 2 parameters: clinical activity and severity, and also duration of Graves orbitopathy. So clinical activity assessment and the clinical severity is very important in assessment of any case of Graves orbitopathy. So most of anti-inflammatory immunosuppressive treatment is less effective after 18 months of disease duration. So it is very important to start this medication as early as possible. A clinical activity score, which is CAS score, is very important, because if clinical activity score is less than 3, this is inactive Graves orbitopathy. If equal or more than 3, this is active Graves orbitopathy. This is a 7 item points. The first and second one is a pain, spontaneous retrobulbar pain, pain in the attempted upward or downward gaze, and the third and fourth, redness of the eyelid or conjunctiva, and fifth, sixth, seventh, swelling of the caruncle, eyelid, conjunctiva. So don't forget that 2 items for the eyelid, redness and swelling, 2 items for conjunctiva, redness and swelling, and the 2 pain, and another one for swelling of caruncle or pleca. The second item for assessment and classification of Graves orbitopathy is classification of severity: mild Graves orbitopathy, moderate to severe Graves orbitopathy, and sight-threatening or very severe Graves orbitopathy. Let's start by sight-threatening or emergent Graves orbitopathy, patient with dysthyroid optic neuropathy and or corneal breakdown. We should refer this patient immediately. Mild Graves orbitopathy is a feature of Graves orbitopathy have only a minor impact on daily life. One or more of the following: minor lid retraction, mild soft tissue involvement, exophthalmos less than 3 mm above normal for race and gender, no or intermittent developing. What about the moderate to severe? 2 or more of the following: lid retraction more than 2 mm, moderate to severe soft tissue involvement, exophthalmos more than 3 mm, inconstant or constant developing. How to manage according to the activity and severity? So a clinical activity and severity should be used for assessment of any case of a Graves orbitopathy, and any case of Graves orbitopathy should be categorized as active or inactive, and a mild, moderate to severe, or sight-threatening activity. Also, any patient with Graves' orbitopathy should be referred to the ophthalmologist or a specialized center in a case of overt Graves' orbitopathy and mild cases at risk to deteriorate. Quit smoking is mandatory and urgently recommended for all patients with Graves' hyperthyroidism, and thyroid dysfunction should be rendered euthyroid be restored as rapidly as possible and maintained in all patients with Graves' orbitopathy, not fluctuating. Glucocorticoid prophylaxis, it is recommended to give oral prednisone or prednisolone should be given to any patient with Graves' hyperthyroidism before receiving radioactive iodine ablation if the patient have a high risk for a progression to development of Graves' orbitopathy. How is the regimen for giving prophylactic glucocorticoid? For the high risk patient, we give 0.3 to 0.5 milligram per kilogram body weight as a starting dose, and covering this dose within 3 months. But if the patient is low risk, in this situation, we will start by a smaller dose, 0.1 to 0.2 milligram per kilogram prednisone or prednisolone, tapered and withdrawn after 6 weeks. So this is a very important if we give a prophylactic oral prednisone or prednisolone for the patient before receiving radioactive iodine ablation. A local treatment like artificial tears is recommended for all patients. Mild Graves' orbitopathy should be trial of selenium, 6 months selenium supplementation should be given to a patient with mild and active Graves' orbitopathy of recent onset. And also, if the impact of the disease affect the quality of life, then low-dose immunomodulatory therapy in active Graves' orbitopathy or rehabilitative surgery in a case of inactive Graves' orbitopathy is recommended. Intravenous glucocorticoid is the best management for moderate to severe active Graves' orbitopathy, and the cumulative dose of intravenous glucocorticoid should not exceed 8 grams for each cycle. And don't forget that Graves' orbitopathy patient with evidence of recent viral hepatitis, significant hepatic dysfunction, severe cardiovascular morbidity, uncontrolled hypertension should not be administered intravenous glucocorticoid because will exacerbate the underlying pathology. And of course, intravenous glucocorticoid should be administered in well-qualified centers. The dosage and how to give a dosage of intravenous glucocorticoid, it is written here in full details. I will not lose the time by this dosage, but everyone can read it. And don't forget that glucocorticoid withdrawal, we should withdraw glucocorticoid by specific protocol. If the patient cannot tolerate a high dosage of systemic glucocorticoid, it is recommended to give a local subconjunctival or periocular injection of triamcinolone acetate can be considered. Also, some of other drugs like mycophenolate, cyclosporine, azathioprine can be used as a second choice or can be combined with glucocorticoid. So, orbital radiotherapy is considered an effective second-line treatment for moderate to severe Graves' orbitopathy in combination with glucocorticoid in the presence of diplopia and or restriction of extraocular motility. The cyclosporine can be given with a combination with oral glucocorticoid as a second-line therapy. Also, azathioprine is considered a second-line therapy. Another very promising drug like teprotumumab is a strong, which have a strong reduction of exophthalmos diplopia, and improvement of quality of life. And actually, I discussed these drugs and modality of treatment in a session of Graves' orbitopathy in full details. And I gave some of recent paper about teprotumumab and give the Graves' orbitopathy picture before treating and after treating, and placebo images. So teprotumumab is currently recommended as a second line option as longer term data availability and affordability, and the cause need a subsequent rehabilitative surgery or pending. Another very important drug, which is rituximab, which is considered as a second line treatment for patients with moderate to severe Graves' orbitopathy of recent onset, less than 12 months. And another drug, which is tocilizumab, is a second line therapy for moderate to severe and active glucocorticoid-resistant Graves' orbitopathy. So, the first line treatment for moderate to severe and active Graves' orbitopathy is intravenous methylprednisolone in combination with oral mycophenolate sodium. And of course, the second line treatment for moderate to severe active Graves' orbitopathy should be second course of intravenous methylprednisolone or oral prednisolone with combination with cyclosporine or azathioprine, or orbital radiotherapy, or teprotumumab, or rituximab, or tocilizumab. This is all second line options. Treatment of sight-threatening Graves' orbitopathy should be treated immediately with high single dose of intravenous methylprednisolone, 0.5 to 1 gram of methylprednisolone daily for either 3 consecutive days or more, preferably in the every second day. And urgent orbital decompression should be performed if response is absent or poor within 1 to 2 weeks. This is emergency condition. And this is just a summary for management of different forms of Graves' orbitopathy. Mild Graves' orbitopathy, general recommendation is recommended to stop smoking, treat thyroid dysfunction, preferable by anti-thyroid drug, especially if the risk factor for deterioration or progression of Graves' orbitopathy is present. Avoid heterogenic hypothyroidism in treating patients with Graves' disease. Refer to thyroid eye clinic if risk factor present. Search for dry eye syndrome. How to manage by local treatment artificial eye, ophthalmic gels like corneal protection gel during the night, and we give systemic adjunct therapy for active Graves by selenium. The quality of life, if markedly impaired, we should give low dose immunomodulatory drugs in case of active Graves' orbitopathy, or rehabilitative surgery in case of inactive Graves' orbitopathy. This is for mild Graves' orbitopathy. What about moderate to severe Graves' orbitopathy? We have two lines: first line therapy and second line therapy. Okay, Dr. Mahawish. And this is moderate to severe and active Graves' orbitopathy. First line therapy gives intravenous glucocorticoid. There are two protocols: 0.5 gram intravenous per week for 6 weeks, or 0.75 gram intravenous for 6 weeks. At the end, if the patient is not improved, we should go to the second line therapy form in another intravenous methylprednisolone or oral prednisolone, or combined with cyclosporine or azathioprine, or orbital radiotherapy, or rituximab, and so on. And actually, this slice I cover it in more details in a Graves' orbitopathy session. So this is the last one: how to manage sight-threatening Graves' orbitopathy. Specific management: intravenous methylprednisolone. I will repeat this because this is an emergency condition, and some of us may face a case like this, and the treatment usually save vision. So, intravenous methylprednisolone 0.5 to 1 gram as a single dose repeated on 3 consecutive or alternative days, and we should monitor ophthalmic parameters daily. After 1 week evaluation, if the therapy can be continued, no response in this situation, we should go to the urgent orbital decompression therapy. If improved after 1 week, So we should go to further intravenous methylprednisolone as in the week 1. If there is response, I will decrease the dose to 0.5 gram intravenous methylprednisolone every week to every cycle, cumulative dose less than 8 gram per cycle. If there is a partial response, I will go to the urgent orbital decompression surgery. So this is actually the last slide in the Graves orbitopathy guidelines, the latest one. And actually I have today the last guideline in this session today, this guideline session today, inshallah. And actually this is just a few slides. 2021 European Thyroid Association guidelines for the management of iodine-based contrast media-induced thyroid dysfunction. No, there are two guidelines. We have two guidelines. This one and another one for assisted reproductive with pregnancy. So this is a guideline about the management of iodine-based contrast media-induced thyroid dysfunction. And actually iodine-based contrast media used for CT with contrast, for example, or coronary angiography, the prevalence of thyroid dysfunction varies from 1 to 15%. Most cases of iodine-based contrast media induced thyroid dysfunction are mild and transient. So it is very important to pick up the people at high risk. And guidelines don't recommend routine baseline thyroid function test before doing this contrast media, before receiving contrast media in a general population. But actually, we recommend thyroid assessment for the patient with high risk for development of thyroid dysfunction. Prior to ICM exposure, we suggest throughout case finding approach. We suggest measuring the TSH, baseline TSH, in a high-risk patient for ICM-induced thyroid dysfunction, especially in the elderly and in the patients subjects at risk for cardiovascular disease. Who at high risk for development of iodine-induced thyroid dysfunction? Iodine-induced thyroid dysfunction, ICM-induced hyperthyroidism, risk to development of thyrotoxicosis will increase in a patient with non-toxic nodular goiter, latent Graves' disease, iodine deficient area like all Europe. Europe is generally considered an iodine deficient constant, and also in a patient with persistent endogenous subclinical hyperthyroidism. So in a patient with non-toxic nodular goiter, latent Graves' disease, iodine deficient area, persistent endogenous subclinical hyperthyroidism, we should reassess thyroid status before iodine-induced contrast media. What about ICM-induced hypothyroidism? Who will have a risk for development of hypothyroidism? Any patient with previous history of autoimmune thyroiditis. Fetus or neonate increase the risk of hypothyroidism. Iodine replete area. Non-toxic nodular goiter, the same as subclinical hyperthyroidism. History of postpartum lymphocytic thyroiditis or thyroiditis. History of partial thyroidectomy. Thalassemia major in conjunction with repeated blood transfusion and a patient with renal failure. Those patients are increased the risk of hypothyroidism after iodine contrast media. So we don't recommend radiological examination using ICM in patients who have overt hyperthyroidism. So the contrast media is not recommended if the patient presents with overt hyperthyroidism. Alternative imaging procedure like ultrasound, MRI, non-contrast CT should be considered in this situation. Persistent endogenous subclinical hyperthyroidism is not contraindicated for this contrast media, but we should establish the etiology. The etiology due to the Graves' disease or toxic adenoma or multinodular toxic goiter is very important to establish the etiology. And if there is untreated subclinical hypo or overt hyperthyroidism are not contraindicated to ICM administration due to the possible exacerbation of hypothyroidism, we should do close monitoring after the contrast media. Patients on thyroid hormone replacement therapy are not contraindicated, but and don't require specific management. Before giving contrast media, we can give a prophylactic treatment in a patient have high risk for hyperthyroidism. But what is the benefits? What is the risk of giving prophylactic carbimazole for a patient with high risk of hyperthyroidism? The positive effect usually we by giving a prophylactic treatment we will stabilize it to SH and free thyroid hormone, and we have a faster normalization in the iodine excretion and thyroid iodine uptake, and we blunt or prevent the induction of iodine contrast media induced hyperthyroidism. But unknown or negative effects, side effects of mesimazole or carbimazole or perchlorate prophylactic treatment. But there are some modifiers like the age, the health status of the patient, the comorbidities, the cardiovascular disease can affect choosing prophylactic or not to give a prophylactic treatment. If we have a patient with a higher risk to presented by hyperthyroidism, we can give a prophylactic treatment before contrast media with mesimazole and or perchlorate before emergency radiological examination in selected patient, especially in the elderly with persistent endogenous subclinical hyperthyroidism or nodular goiter and or concomitant cardiovascular disease, especially in the area of the iodine deficiency like Europe. What is the protocol and what is the regimen? And actually I put this slide from the guidelines because it is very important. One of the protocol is by giving 60 milligram of mesimazole and 1 gram of sodium perchlorate 24 hours before and on the day of coronary angiography. This is a one approach. Another approach recommended by Australian Thyroid Association by giving perchlorate as a preventive treatment. They give 600 milligram prior to the examination and continue with three times per day, 300 milligram daily for 7 to 14 days in high-risk patient. But the guidelines recommend, and this is recommended in many countries, by giving mesimazole 20 to 30 milligram daily, starting the day before contrast administration and continue for 2 weeks. And actually, I prefer this method by giving mesimazole 20 to 30 milligram daily from the 1 day before the contrast administration and continue for 2 weeks. And of course, the contrast administration may cause a transient change in the serum TSH, T4, and T3 level in healthy individual, and this may last for 1 to 3 months after this administration. And the guidelines does not recommend routine TSH monitoring following the contrast administration. And actually, exact time of thyroid dysfunction is often unpredictable, and we should put in our mind measuring thyroid status 3 to 4 weeks after the contrast exposure may be affected by this contrast media. So the value may be misleading. We recommend avoiding isotopes imaging of the thyroid and radioactive iodine treatment for 1 to 2 months after contrast injection. So 1 to 2 months radioiodine is not recommended either treatment or scanning after contrast media. And of course, they recommend evaluating patient with a newly diagnosed hyperthyroidism should be concerning the possible previous radiological examination that may affect diagnosis and treatment. actually within 2 to 3 months after contrast administration. السيرم TSH is the best modality for screening as initial test. If TSH is low, T3 and T4 should be followed. If the diagnosis of contrast-induced hyperthyroidism is not apparent based on the clinical presentation, they recommend assessment by urinary iodine concentration to support iodine excess as a cause of hyperthyroidism and to monitor treatment. So, if we cannot determine if the contrast-induced hyperthyroidism is the diagnosis or Graves' disease, we should go to urinary iodine concentration, which is elevated in a case of contrast-induced hyperthyroidism. And of course, we should individualize approach for a treatment of contrast-induced hyperthyroidism regarding clinical symptom and etiology and severity, and the patient age and concomitant disease like cardiovascular disease and clinical status. For the mild cases, we recommend a close monitoring and avoid further excess of the iodine exposure and give beta blocker. In severe cases, we recommend initiation with methimazole, carbimazole, or propylseracine. In case of partial response to antithyroid drug, a combination with perchlorate is helpful. But in a case of mild contrast-induced hyperthyroidism, should be treated in a patient older than 65 years, particularly in the presence of comorbidities by carbimazole. What about contrast-induced hypothyroidism? TSH is recommended as the initial screening test. If TSH is high, in this situation, we recommend measurement of T4 level alone, not T3. We recommend measurement of thyroid peroxidase antibody if the etiology is not clear. In a case of a newly diagnosed hypothyroidism, concerning previous radiological examination using contrast media in the last 1 to 2 years. This is very important. So, the contrast media can affect thyroid status by causing hypothyroidism even for 1 to 2 years after this contrast media. And in this situation, spontaneous remission might occur over time without the need for lifelong temporal levothyroxine treatment. They recommend individualized approach for treatment of contrast-induced hypothyroidism based on clinical symptoms, etiology, severity of hypothyroidism, and also patient age, concomitant disease, and clinical status. And of course, in this situation, we suggest a close monitoring without thyroid hormone replacement therapy and for mild cases of contrast-induced hypothyroidism. And also, treatment by levothyroxine for short duration may be considered, especially in the younger patient with symptoms, or a younger patient with a chronic autoimmune thyroiditis, or in a female planning for a pregnancy. But in the elderly is not recommended. So, elderly patient presented with contrast-induced hypothyroidism, subclinical hypothyroidism, should be carefully followed, generally avoiding levothyroxine. And lastly, they suggest careful monitoring of thyroid dysfunction in infant after maternal or neonatal contrast exposure. And actually, this is the last recommendation from these guidelines. And actually, I have just 3 or 4 slides in this guideline session. I know that the last guidelines is tough, but actually we face a lot of cases presented before or after contrast media with thyroid dysfunction. So you need to repeat these guidelines several times to be familiar with it. So the last guideline today, inshallah, this is the European Thyroid Association guidelines on the thyroid disorder prior to and during assisted reproduction. First of all, several thyroid dysfunction may lead to menstrual disorder and subfertility. And in some situations before assisted reproductive technology, ovarian stimulation is used, but don't forget that ovarian stimulation usually leading to high estradiol level that lead to hypothyroidism. And this indicate to be treated by levothyroxine, especially in a woman with thyroid autoimmunity. Woman with hypothyroidism treated with levothyroxine prior to ART should have a serum TSH less than 2.5. And this actually is a very repeated question in the exam. The target of the TSH less than 2.5 for female seeking fertility. A subfertility woman with hyperthyroidism planning to ART procedure should be informed of the increased risk of maternal and fetal complication. So, levothyroidism should be restored and maintained for several months prior to an ART treatment. And this actually is very important in clinical practice. So, levothyroidism should be restored and maintained for several months prior to ART treatment. Fertilization rate and embryo quality may be impaired in the woman with TSH more than 4 and improved with levothyroxine therapy. So this is a summary of the guidelines. They recommend that all women seeking medical advice for subfertility is doing screened by TSH and TPO and TG antibody. TG antibody can be added, especially if the TPO antibody is negative. They recommend TSH level more than 2.5 and without increasing TPO level to screen for TG antibody. They recommend against systemic screening for thyroid disorder by TSH and TPO for males with subfertility. We suggest screening for thyroid dysfunction TSH in the men with ejaculation and erectile dysfunction and or altered semen parameter. We recommend here men who desire fertility and need to undergo ablative radioactive iodine ablation to wait at least 4 months before attempting conception. So this is a different than, this is the same as Oxford Handbook and different than European Thyroid Association guidelines for management of Graves' disease. So in this guidelines, they recommend the men who desire fertility and need to undergo an ablative dose of radioactive iodine to wait at least 120 days. So this is 4 months before attempting conception. And so levothyroxine treatment should be started promptly in the woman in a case of overt thyroid dysfunction, and also in a woman with thyroid autoimmunity. So thyroid autoimmunity means TPO is positive or anti-TG is positive. And the TSH is more than 4. In this situation, we recommend to keep TSH is less than 2.5. Also, in a woman without thyroid autoimmunity and the TSH is more than 4, it is recommended to treat if the TSH is more than 4 to bring TSH to be less than 2.5. And they recommend adjusting levothyroxine dosage in a woman already treated with subclinical hypothyroidism before ovarian stimulation to keep TSH is less than 2.5. Also, if the TSH is more than 2.5 and less than 4, in this situation, we should start a low dose of levothyroxine, usually 25 to 50 microgram before ovarian stimulation on a case-by-case basis. If the patient is euthyroid without thyroid autoimmunity, it is not recommended to treat with levothyroxine. Check TSH level after ovarian stimulation in women with thyroid autoimmunity under levothyroxine treatment. Don't recommend serum TSH monitoring after ovarian stimulation in any euthyroid woman without thyroid autoimmunity unless treated with levothyroxine. We suggest that euthyroid woman with thyroid autoimmunity undergoing IVF or X should not be treated systemically with levothyroxine. In euthyroid female, even with thyroid autoimmunity undergoing IVF or X should not be treated systemically with levothyroxine and also not with corticosteroid. And actually, this is the last slide in this guidelines. This is algorithm summarize all of this guideline. In any patient subfertile female, the best test is by doing TSH and TPO antibody and TG antibody. If TSH is less than 0.3, this is a thyrotoxic patient. In this situation, I will do T4 and T3. If it is normal, this is a subclinical, and in this situation, I go to routine care. But if free T3 and free T4 is increased or decreased, in this situation, this is a case of central hypothyroidism or overt hyperthyroidism, and in this situation, I will postpone ERT and perform endocrine workup, full assessment of thyroid status. So this is overt hyperthyroidism, and I should postpone ERT. What about if TSH is normal between 0.3 to 2.5? In this situation, I will check TSH only after ovarian stimulation if treated by levothyroxine. But if not treated by levothyroxine, no need to check for TSH. What about the TSH is between 2.5 and 4? In this situation, if the patient thyroid autoimmunity, in this situation, I will treat by levothyroxine. If thyroid autoimmunity is positive, I will initiate levothyroxine and control TSH to be less than 2.5 before starting ovarian stimulation. Thyroid autoimmunity is negative and ovarian stimulation is indicated. In this situation, I will check TSH after ovarian stimulation. If TSH is more than 4, in this situation, I will treat by levothyroxine and assess TSH before starting ovarian stimulation. So, levothyroxine dose depending on the baseline TSH level and the body weight. We should start by 25 microgram when TSH is between 2.5 and 4, and our target is TSH is less than 2.5. And we can start by a higher dose, for example, 50 microgram levothyroxine if TSH is more than 4. So this is the last slide in this guideline. If anyone has a question, please let me know. I cover all the guidelines and actually in about 5 or 6 hours. So if anyone has any question, it is welcome. Before starting another topic, and actually, yes,
I want to ask about if the patient TSH between 2.5 and 4 and autoimmune negative, we need to start L-thyroxine or not? I missed this point.
Actually, in this situation, the guidelines does not recommend starting thyroxine except if the patient is presented by repeated abortion, for example. In this situation, I will recommend starting levothyroxine by small dose. But actually, guidelines does not recommend starting levothyroxine if it is less than 4 and thyroid autoimmunity is negative. TPO antibody is negative, TSH receptor TPO antibody negative, and TG antibody negative. In this situation, levothyroxine prescribing is not recommended except in a very limited conditions. The patient is presented by repeated abortion. I will recommend start small dose. Before ERT or ovarian stimulation, it is recommended to bring TSH to be less than 2.5. So in this situation, I will start by a small dose of levothyroxine. But routine prescribing levothyroxine for a female with negative autoimmunity and TSH is less than 4 is not recommended.
Okay, thank you.
Dr. Khalid?
Yes.
In Pakistan, there are many physicians who are giving dose of thyroxine in a very high amount, like a patient of 65 kg, and if it's his TSH is very high, like about 20 or 25, they are giving 4 tablets of thyroxine of 50 micrograms. It's not in the dose of 1.6 microgram per kg per day. They give in higher dose.
Actually, in most cases of overt hypothyroidism, we will start levothyroxine by a dose related to the body, 1.6 microgram per kilogram per day, and adjust this dose according to the TSH level after 6 to 8 weeks of after initiation of levothyroxine. But during the pregnancy, we will start by a dosage more than this in overt hypothyroidism to rapidly correct the TSH. So in a pregnant female, we can start by 2 to 3 microgram per kilogram per day. So Zoom will shut down within 1 minute, and we will take a break for 15 minutes, only 15 minutes, and I will start again. So these guidelines, I already upload this PDF to the subscriber, and actually this is the profile for thyroid disorder previous sessions, and inshallah within 2 weeks I will start diabetes session. Inshallah, this is I will start 9th of September. Inshallah, the first session in the Bismillah course. This is a paid course. And so we will go back after 15 minutes from now.